Hello, everyone. Welcome back to the Tokyo Living Podcast. This is the second episode in a series that we're doing on common areas of pain and common injury sites. On today's episode, we're going to be talking about knee pain, and in particular, anterior knee pain, so pain at the front of the knee. And even more specifically, anterior knee pain of gradual onset, so of non-traumatic onset. So essentially something that sort of comes on gradually due to overuse or for apparently no reason. We'll sort of go into detail on why that might be. When we get traumatic or acute pain in front of the knee, it's often related to things like dislocation of the kneecap. It might be related to a direct fall on the knee, which may cause damage to the bone, may cause a fracture to the kneecap or the patella. Or it may cause swelling or inflammation around the bursa around the knee, which are sort of sacs of fluid that are designed to limit or decrease friction in those areas, and they can be damaged through impact. So those type of conditions require a different course of management, and they're slightly different in the type of pain that they cause. So today we're talking about sort of chronic or overuse injuries or pain to the front of the knee. Now, usually pain in this area is related to issues with the kneecap or with the joint between the kneecap and the thigh, which we call the patellofemoral joint. Now, the kneecap, knobbly little bone sticks out at the front of our legs. Might be wondering what it's there for. The kneecap or the patella essentially acts as a fulcrum for the quadriceps, the muscles at the front of the knee, to pull on the shin, the bone of the lower leg, to basically straighten the knee. So essentially that's what the quadriceps do. We can be a little bit more nuanced in their role, but essentially the quadriceps are there to straighten our knee. So if I'm going to stand up from this chair, my knees have to straighten to do that. If I do a squat, that's exactly the same thing, but I'm putting an external load on, so I'm making those quadriceps as well as other muscles have to work harder. If I'm running, every time I'm pushing away from the ground, the knee is straightening under load, so those quadriceps are working. And so the patella essentially provides a biomechanical advantage to the quadriceps rather than going straight down onto the shin where they wouldn't really have leverage to pull and to straighten the knee. The patella acts as, like I said, a fulcrum for the quadriceps to go over and give them a little bit of a mechanical advantage there. So what happens when the quadriceps go over the knee? In order for that function as a fulcrum to occur, there needs to be pressure placed on the knee. And so that pressure placed on the kneecap, placed on the patella, is transmitted through to the joint between the thigh and the patella, through to that patellofemoral joint. So every time we are bending and straightening our knee under load, every time I'm standing up and sitting down from this chair, there is a certain degree of muscular tension that's produced in those muscles, and that's basically compressing the kneecap against the thigh. And then it's sliding the kneecap under that compression over the thigh as we stand up. Now, this is a very normal thing to occur, and it's part of the way that our bodies were designed to perform our normal lower limb functions. Just like everything, however, if we overdo that action, if we run too much, if we squat too much, if we do whatever activity it is, then that joint between the kneecap and the thigh has the ability to be overloaded. And when it gets overloaded, it goes through a number of different chemical and neural processes, which are far beyond the realm of this quick podcast, that start to cause a painful response. Not necessarily inflammation. There may be some inflammation involved, but it's an increase in the sensitivity of that joint. So now, once that joint becomes sensitized, when we're doing those actions like squatting and we're bending the knee with that contraction of the quadriceps, which is providing compression of the kneecap, we're starting to get pain because of that increased sensitivity in the area. And this, if we go back to the last episode when we talked about the different types of load, this is what we call our tissue-specific load. So why has this come on? In most cases, it's because we've changed something to do with our activity. So we've ramped up the amount of exercise we're doing, we've ramped up the amount of the resistance training or running, or all these fantastic things that are great to do. But if we do a little bit too much too quickly, they can start to cause some issues with certain parts of the body. It may be that we've done that gradually. We've tried to progress from running 5 kilometers to running a marathon in 6 weeks, and that's just put a little bit too much pressure on the joint. Or it might be that we've been relatively inactive, and then we've gone and done a lot of exercise. We're trying to be healthy. We've started that health kick, and we've done a lot of exercise in the space of a couple of weeks or even 1 week, and it's just caused things to be a little bit sensitized and overloaded. On the other side of things, so if we go back to last episode, when we talk about the indirect tissue-specific load, talking about the biomechanics, there might be other things going on in our body that are leading to increased pressure in that joint. So we might have classic examples are stiffness in the ankle. So the stiffness in the ankle might mean that we're not functioning in an optimal way when we're putting load through our lower limb, and because of that, it's putting a little bit too much pressure on that patellofemoral joint and causing it to be sensitized. We might have some weakness in the hips that when we're doing those movements that are involving what we call triple extension, when let's say we're jumping off our leg and we're having to extend the ankle using the calf, the knee using the quadriceps, and the hip using the gluteal and the hamstring muscles, the buttock muscles there. If there's decreased strength in other areas, then the quadriceps are going to have to overwork, and therefore there's more stress going through that patellofemoral joint. And again, we can overload that area. And then again, going back to last episode, there's all those other aspects around pain, things like our general health, our nutrition, our sleep, our hydration, psychological stress, the beliefs that we have about our pain. All that can sort of feed into increased sensitivity in that area, or increased sensitivity in tasks that load that area. So in that case, how do we go about treating it? Well, like everything, we need modalities that help settle the pain down, and then we need to build our tolerance back up, build the load back up, so that we get to the point where the patellofemoral joint can tolerate the loads that it needs to for the activities that we want to do. So that initial stage of the rehab might involve things like taping. We have some very effective taping methods that can offload the stress of the patellofemoral joint, either by taping around the kneecap directly, or taping the thigh and shin in certain ways that offload the kneecap. And that can be really effective in getting things to settle down. It might be just an amount of relative rest. This is a case-by-case thing. If someone has been completely inactive, or not, relatively inactive, but they're still experiencing their symptoms, then it might be a case of just trying to get them moving and actually getting a bit of load through there to try and decrease the sensitivity and promote some adaptation. If someone is still pushing through their exercise, it may just require a small amount of time backing off, so that that area has a bit of a chance to rest and to settle down. It might involve other modalities such as manual therapy, some mobilization, some massage, soft tissue work, acupuncture, things like that. Maybe even if it's a very stubborn condition that won't settle down, it may even require an injection in the area. But that's something that we generally don't need to get to with these type of conditions. So once we've got our pain to settle down, we can start sort of building the load up. So we start to challenge the knee. So let's say we experience some pain with a full squat. We might start off with a half squat and then gradually increase the depth of that squat. And then if the pain is related more to the angle that we're bending rather than the actual load that we're using, we might be able to do very shallow squats whilst using heavy weight. So we're still getting some load through the leg. We're still forcing some adaptation, but we're not putting it into the range where that sensitized area of the kneecap, because it may be just a very specific area of the patellofemoral joint that's sensitized, that only gets in a position of maximal compression at certain angles of knee bend. So we can sort of modify exercise in that way. If there is a biomechanical component, like we talked about before, if there's some ankle stiffness, if there's hip weakness, we basically just assess those areas individually, and then we apply a targeted exercise program to address that. So it might be some ankle mobility work, it might be some hip strength work, and there's a number of other things that might be causing it. If it's a technique issue with sporting technique, or let's say someone is experiencing some pain when they run, we might even modify their running gait, have them run at a higher cadence, for example, for a short period period of time to allow those symptoms to settle. And then over time, we can just build back that load, and based on that person's response. Again, if there's all those other things contributing, the nutrition, sleep, all that type of thing, we go through systematically. And if we believe that something is related to the pain, we address that individually. So that's our basic treatment approach for patellofemoral issues. What happens though, sometimes someone might see a doctor about this, and they send them off for imaging. This is a very common presentation, and imaging, we've done episodes when we've talked about imaging in the past, and imaging is fantastic. I'm just reading back recently on I think it was the 2002 Nobel Prize winner was the guy that established the MRI. Imaging has done amazing things for orthopedic medicine, for medicine in general. We can see things in a lot more detail than we used to be able to, and we can have more precision to find non-musculoskeletal causes of pain, and things that are very serious and sinister, and things that we want to rule out. However, we do see a lot of things that are irrelevant. And so often with knee pain, someone will be sent off to an MRI, and it can show a number of different things. Some things that might show are meniscus tears or cartilage tears in the actual knee joint itself. So now we're not talking about the articulation between the kneecap and the thigh. We're talking about the shin and the thigh. Or meniscus, those rings of hyaline cartilage that sit between the knee joint. And these sort of things are very common in asymptomatic individuals. So there's a lot of people walking around with meniscus tears, big old meniscus tears, that have never had knee pain in their life. The presentation associated with a meniscus tear, for the most part, is quite different, both in the onset, both the history that someone with this condition would present with, and also the findings on a clinical examination. And so for most cases, we're able to look at a knee, to assess a knee, and have a good idea whether it is more of a patellofemoral joint issue or whether it's a meniscus issue. And usually with a meniscus, you're not going to get that classic pain in the front of the knee. Unfortunately, what happens is someone might go off, have an MRI showing a meniscus tear, take that back to the doctor. The doctor will look at that and say, that's your problem, and then send you off for surgery. And if you've had a patellofemoral joint issue and you have meniscus surgery, that's not going to help with your issue, and it could very well make things worse, because now you're dealing with the trauma, the inflammation, everything that goes along with the surgery, the deconditioning. And if the knee pain, the anterior knee pain, initially came on partly as a result of deconditioning, then that's going to make that whole process worse as well. So we've got to be really careful with how we interpret imaging findings in other parts of the knee. The other thing that it might show is some change in the patellofemoral joint itself. So the joint surfaces, the cartilage surfaces, can be worn over time, and they can have areas of generalized wearing, or they can have areas of focal wearing. You might have a very focal cartilage defect. Traditionally, this sort of change in the patellofemoral joint has been termed chondromalacia patella. This is not really a term that we use anymore in modern sort of evidence-informed sports medicine. Chondromalacia patella just means that the patellofemoral joint is worn, which doesn't really tell us much about the pain. As we've talked about, there's a lot of different causes that can cause the anterior knee pain. And so whilst change, degenerative change in the patellofemoral joint in terms of the cartilage surface may predispose someone to experiencing pain in that area, it doesn't necessarily mean that they're going to have pain in that area. And it also doesn't necessarily mean that a surgical intervention is required. So even in a relatively degenerative joint or joint surface, you can still develop the ability to tolerate load if that said load is applied gradually enough. And if you're watching the video version of this, you can see an MRI of my lovely knee. This is a 41-year-old, actually, I lied, this was taken a few years ago. This is a 38-year-old knee. If you showed an orthopedic surgeon, they'll probably tell you that that person in the MRI machine is about 90 as a result of 3 knee surgeries, 2 anterior cruciate ligament reconstructions in the space of 18 months, and 20 years of competition in elite level karate. That has left this knee, both the kneecap, the patellofemoral joint, and the rest of the knee in a pretty degenerative state. So I've definitely got chondromalacia times 10 there. However, I can squat more on this right leg and deadlift on this right leg more than a lot of people can squat on both legs. And I can still perform martial arts at a very high level, and I don't have any pain. So that sort of proof just there that the joint surface, whilst it's not that it's not relevant at all, there's certainly the capacity to develop load tolerance and to decrease sensitivity, even in a joint structure that doesn't look particularly pristine. So if you have had pain in this area and you go and see a doctor and they tell that you've got some changes in the kneecap, and heaven forbid they tell you that you've got this chondromalacia patella, it almost sounds like an evil character from a movie. It's a horrible sounding word. I just don't feel nice saying it right now. But if you have got those findings and they might be suggesting surgery as a first option, then certainly try and get a second opinion. It's not to say that surgery is never required. Sometimes it is required, and sometimes we do have good outcomes after surgery. But unlike other areas of the body, surgery for anterior knee pain isn't often all that successful. So we really do sort of save this as a last resort. Some surgeries need to be done straight away and are very useful and have very good outcomes. But this is one area that I'm not a big fan of surgery for. So that's basically the patellofemoral joint. Now, there are other specific conditions that can cause pain in this area. The patellar tendon, where the quadriceps muscle, the muscle at the front of the thigh, joins onto the shin. Anyone who studied biology or anatomy up to a certain level knows that tendons attach bones to muscles or muscles to bones, and the patellar tendon can be overloaded in the same way. Now, the type of activities that cause a patellar tendon to be overloaded are likely to be different to those that cause the patellofemoral joint to be overloaded. It's more those activities associated with high tendon load, which is what we refer to things like jumping and bouncy type movements. So if you're a basketball player or a volleyball player and you're doing a lot of jumping, then you're at a higher risk of getting a patellar tendon issue. You can have, and these are the diagnosis in a clinical examination is also fairly straightforward. This is not something that requires imaging. And again, you can have pain in the patellofemoral joint. Go and get a scan. It shows some patellar tendinopathy, what was previously called patellar tendinitis. Again, it's not really a term that we use commonly really at all, the tendinitis. When you have a problem with the tendon, it's not sort of inflammation in the traditional sense. But that might show up on a scan. And again, if it's not consistent with the findings on a clinical examination, then it's not really relevant. But we can identify patellar tendon issues on a clinical examination fairly easily. Things where a squat might be not so painful, but a jump is a bit more painful, and a hop is really painful. It's classic sort of patellar tendon signs. And then with a focal palpation, so we feel around the area, we can identify that area of sensitivity. We might also have a fat pad issue. So fat pads. The commonly injured fat pad sort of lies directly under the patella to give it a little bit of a buffer and some padding under there. And that can sometimes be overloaded with tasks that involve a lot of straightening, hyperextension of the knee. And so those sort of conditions will require a bit of a different treatment approach to the patellofemoral joint, but the building up and developing the capacity to tolerate load is still the same. It's more so the initial management that might change a little bit in terms of how we offload those structures. In younger individuals, we have conditions such as Osgood-Schlatters traction apophysitis, so where the patellar tendon, rather than the actual tendon being irritated, it's the area of the growth plate where the tendon attaches in younger individuals, typically sort of early teens or younger individuals, in boys sort of around 10, 11, 12, girls maybe a little bit younger, where that area gets under stress and it gets pulled, and these people can develop a specific type of pain, and again, it's modifying activity to back off, but also increasing the capacity to tolerate load, and we can usually have a good outcome long term with these sort of patients. I'm sort of getting sidetracked here. I wanted to talk mainly about patellofemoral pain, and I hope that's given you a little bit of an idea about why the majority of people who have pain in the front of their knee have pain in that area, and what we might be able to do about it, and some things that we should avoid in terms of early imaging or inaccurate interpretation of imaging. So, yeah, if you are suffering pain in the front of the knee and you think that you might benefit from some further consultational information in the area, please don't hesitate to contact us. I hope that's been of interest to you and haven't dragged on too long. I will try my best to make these shorter and shorter as we go along, but I will look forward to seeing you or talking to you again on the next episode of the Tokyo Living Podcast. Have a great rest of the day.